To be doing is present. I will be presenting some research that is done as a part of really big team science. I work with some amazing people here at Indiana University, with folks in Sweden, Chicago, and other places. And I'm very grateful for all of their input. I also want to acknowledge funding sources, including the American Foundation for Suicide Prevention, which has been very generous in supporting our work, both on the etiology and treatments that influence suicide. I also want to point out that I do not have any financial conflicts of interest. I do not take any money from pharmaceutical companies, so there is no bias there in terms of conflicts of interest. To give you a heads up about what I'm going to be talking about today, I'm first going to be talking a little bit about research methods, particularly what role can randomized controlled trials play in our understanding about how to treat people with mental health conditions. I'm then going to talk about some of the limitations associated with those trials and talk about different ways of studying it. The bulk of the presentation today is going to be based on our work on ADHD medication. And I'm going to spend a majority of the time talking about one study that's related to really serious substance use problems. These are highly correlated also with suicidal behavior. And I will then summarize a bunch of different research studies that we have done both in the United States and in Sweden. I will then summarize and talk about, well, what are the clinical and research implications of this research? So here's just a roadmap of what I'm going to be covering. So first, there's always a question about how do we make decisions about what type of intervention or prevention efforts do we want to provide to people? And Michael Rawlins, who's a very well-known researcher, wrote in one of the largest British medical journals this article that tried to summarize, well, how should we make our decisions? And a lot of medical decisions primarily are based on randomized controlled trials. And randomized controlled trials are wonderful in the sense that you have a group of people who all have a condition, let's say ADHD, and then you randomize half of the group to get a medication and the other half gets a placebo. And then at the end of the study, any differences that you see among those people, you can infer is due to the medication. And what he said is that a bunch of research groups have tried to put a hierarchy. So if you're a decision maker, whether you're a clinician, whether you're an administrator at a hospital, if you're trying to think about policy, he said that these different groups come up with these different hierarchies. And at the bottom, it's just, well, expert opinion. Well, people think that they know what they're talking about. And you can see that that gets a 4. And what's the best is that if you have multiple randomized controlled trials that you can synthesize together using an analytic technique called meta-analyses, and that should guide your decision making. He points out, though, that if you actually look at different medical groups, they actually have different hierarchies. And what he basically concluded is that a priori, you can't meaningfully place research in some hierarchy. And the reason why you can't do that is that there are major flaws in each and every approach to studying interventions. And in particular, there are major flaws with randomized controlled trials, okay? I love randomized controlled trials. If I could do them well, I would. But most randomized controlled trials, particularly in the field of mental health, cannot study rare outcomes. They are not large enough to study things like a drug overdose or death due to suicide. I want to contrast that with randomized controlled trials that are now being done on these new weight loss drugs, these GLP-1 medications, where they are randomizing 10,000 people. That's amazing. The largest study of ADHD medications is less than 500 people. And thankfully, some of the outcomes that we're interested in are not common enough to be able to study in 500 people. So we don't know about ADHD medications' effects on rare outcomes like mortality, substance use problems that lead to overdoses, and so on. Plus, there's a question about the generalizability of the findings. Well, who participates in these studies? And what studies have shown for mental health problems in particular, in ADHD in this context, is that some patients get excluded. And the patients that get excluded are those who have the most severe forms of ADHD or who have lots of comorbidity. So for example, if you have ADHD and you have active suicidal ideation, you will not be included in a randomized controlled trial because you need to get additional services for suicidal ideation. But in real world settings, people who have ADHD and suicidal ideation are the people who are actually getting the medications. So our ability to infer how to treat people who actually aren't in our studies is quite limited. Plus the treatments that we use in terms of the dosing, the timing and the duration. A lot of people use ADHD medications for years, but the largest randomized controlled trial has only basically lasted 1 year, 2 years at most. So we don't know about the long-term effects of ADHD medications because it frankly isn't feasible or ethical to randomize somebody to get medication for years and other people not to. And then there's questions about the settings. These are frequently done in large medical centers in large urban areas. And we have found when you compare people who are in those studies to the people who aren't, people who live in rural communities are less likely to be engaged, people who live in poverty, people who are going to be getting treated by people who are non-specialist as well. So we really don't know how to generalize our findings to different patients, different types of treatments, and in different settings. Okay? And a lot of people have actually commented on this, that these randomized controlled trials are quite limited. And this bottom article is written by Angus Deaton. He is a Nobel Prize-winning economist at Princeton. And they asked him at the end, well, actually at the end of the article, he says, well, the editors asked, well, wouldn't I want to take a medication that was studied in a randomized controlled trial? And he said, well, only if those patients were like me. Okay, now this is a full professor at Princeton saying this. What about the rest of us mere mortals, and particularly groups that are underrepresented in research? So how do we proceed? How do we proceed when we know that randomized controlled trials, particularly with mental health conditions, frankly, aren't that generalizable? And a lot of people have written about this, that we need to use large data and big data. And can we use data that's collected for other purposes and use that to study different types of interventions? And that's what I'm going to be talking about today, okay? But how do we make causal inferences? How do we know that what we find is actually due to the medication or not something else when we're not able to randomly assign half the people to get it and half the people not? And what a lot of people have said is that when you do not have the ability to randomize some patients to get treatment and some patients not, is that you have to think ahead of time about what are all the different possible alternative explanations and hypotheses, okay? And that you need to test them. And what most studies do is they use a bunch of other measures and they try to match people, statistically try to match people, those people who got the medication to the people who didn't get the medication. And there you're trying to make inferences by saying, well, we're trying to just compare people who are similar. But we know in terms of research, our ability to actually match people really, really well is quite limited. So controlling for these other constructs, these other explanations that could account for why medications could be associated with an outcomes is incredibly difficult. So people in a lot of different disciplines have said, instead of just relying on trying to match people with statistics, let's try to use sophisticated research designs. And because no research design is perfect, including randomized controlled trials, is that we need converging evidence from a bunch of different designs. Some of the designs that I'll share with you today, along with randomized controlled trials, to help clinicians and physicians and policymakers make decisions along with patients and their families about the best way of treating mental health problems. And what this field is referred to as translational epidemiology. So epidemiology is a field of research that uses these large and representative data sets. And translational is how can we use these sophisticated designs with this data to really study different types of interventions and different types of prevention efforts. So that's just a quick background on methodology. And what I'm going to do now is start and turn my attention to ADHD. Okay, I'm going to quickly go over ADHD. So by definition of what it's called, is that ADHD is a disorder that is associated with pervasive problems with inattention or hyperactivity and impulsivity that you see across a number of different domains, and that it is so severe that it impacts people's daily lives in terms of their schooling or their work or their relationships. It's actually quite common. In the United States now, 13% of youth will be diagnosed with ADHD by the age of 17. More and more adults are being diagnosed with ADHD as well. The other important thing is that people hadn't thought, oh, well, this is something that most people grow out of. But what we're actually finding is that this is not just a disorder of children and adolescents, that most, 90% of people who are diagnosed with ADHD as a child continue to experience symptoms of ADHD that are impairing even through early adulthood. So in contrast to initial theories that most people grow out of this is actually not the case. So treating ADHD is incredibly important because it is impairing. It impacts people's school and work and relationships. And we know that ADHD is associated with a host of really bad problems, including having more problems with substance use problems, more problems with suicidal behavior, whether that is suicide attempts or deaths due to suicide, and a number of other types of difficulties. Well, what about ADHD medication? This is something that is incredibly controversial, particularly in the field of childhood and adolescent psychiatry and now in adult psychiatry. But what we do know from lots and lots of randomized controlled trials is that these ADHD medications have short-term effects on ADHD symptoms. In terms of effect sizes, ADHD medications have some of the largest effect sizes, meaning that they are one of the most helpful ADHD medications that we have, or mental health medications that we have. No, they are not perfect, but relative to other medications for other disorders, they're actually quite good, and they work in the short term. But there are serious questions about ADHD medications, both in terms of concurrent problems and then long-term problems. And people are particularly concerned that giving people ADHD medications, most of which are stimulant medications, could actually have iatrogenic or bad outcomes that you don't intend. Okay? So for example, if you look in the popular media, this was an article in the New York Times years ago about this young man who actually died of an overdose. And the whole article is that basically the ADHD medications that he was given caused him to have more substance use problems. There were reviews. Well, should we give people ADHD meds? Will it actually help with other types of things like substance problems? Well, this is not helpful if you're a clinician, and the answer is still maybe. And then there's other controversial reviews where people were saying if any medication study was funded by a pharmaceutical company, you should not trust it. So physicians are working in a period in which they do not have a lot of insight on what are the risks and benefits of different ADHD medications. And again, as things that I pointed out earlier, randomized controlled trials have not been able to look at serious outcomes. And these are outcomes that are of quite relevance to a lot of patients. And then these observational studies, these studies types that I'll talk about, if you find that an ADHD medication is associated with a bad outcome, is it due to the medication? Or is it due to what's referred to as confounding by indication? Meaning, is it actually due to the fact that they have ADHD in and of itself? And how do you disentangle what are the effects of ADHD from what are the effects of ADHD medication? And that's what I'm going to talk about for the rest of the talk. One way of trying to disentangle the effects of medication from ADHD. So I'm going to talk about an analysis that we did using a really large data set in the United States. Okay. So first, this US data set, it's called MarketScan. And what MarketScan has done, it's now owned by IBM Watson, is they went to insurance companies and they took all of the information from insurance companies and de-identified it. So every time you go to the hospital or to a doctor or get a prescription, those facilities have to tell the insurance company, you need to give us money and this is the reason. Here are the diagnoses, this is the medications they picked up. So this is people who have private insurance, okay? About 50 to 55% of the people in the United States have this private insurance. This is through employers. So most employers especially large employers, will provide insurance to their employees. So this includes the employees, their spouses, dependents, and other people. And one of the nice things about this data set is that it's enormous. So between 2005 and 2014, there's 146 million people. So just in 1 year, 51% are female. And because we're in the US, sometimes you can have health insurance, but actually not have drug coverage. And people are covered for different periods of time, because if you lose your job, you'll lose your insurance. Or if you switch jobs, you might move to a different type of insurance. This is in contrast to what I'll show you what happens in Sweden. But what we were able to do is take this huge data set and identify people with ADHD. And instead of comparing people with medication to people who didn't get medication, we were able to use a sophisticated design called a within-individual analysis, or a within-individual comparison. So here, instead of comparing unrelated individuals, some who got a medication and some who didn't, we are looking within an individual. We are looking at what is the risk of a bad thing happening when a particular individual has their medication versus what is the risk of bad things happening when they don't have their medication. Okay? So we're using this longitudinal information to make comparisons within a person. So instead of trying to statistically match people, we use individuals as their own control. And this rules out everything that is stable over time. So all stable factors, your upbringing, okay, your genetic risk, is all ruled out by making these within individual comparisons. Okay? And we do know that things change over time, so we are able to add other types of measures and statistically adjust for those. Are you taking other medications, for example? Okay. So what I'm going to show you is a really large study using this design with that data set that I was just referring to. So our sample in this study that was published in 2017 included about 3 million people who were diagnosed with ADHD. Okay? This is in contrast to randomized controlled trials where you're lucky to get a couple of hundred people to study an ADHD medication. So our exposure is, did they have medication coverage at a monthly level? Because this is in the United States, most people are getting a stimulant, whether that's methylphenidate or amphetamines. Okay? There are a couple of people who are getting some non-stimulants, but over 80% of the prescriptions are stimulants. And our outcome is going to be a really severe outcome. We're going to say, you're going to have a major substance use problem if you receive treatment in an emergency department or you are hospitalized because of a major substance use disorder. Most of these outcomes are drug overdoses. Okay? So these are really acute, severe events. Okay? And what we're going to do in terms of the methods is we're going to say, what is the association between ADHD medication at a monthly level and these really rare outcomes, as well as what happens 2 years down the road? Okay? So I'm going to show you a bunch of results using this figure. Okay? This figure down here, this is an odds ratio. This is a magnitude of the association. So if there is an association of 1, that means there's no difference. If there's something over here, that's going to say that ADHD or the medication is associated with more problems. And if it's below the 1, then that's going to mean that ADHD or ADHD medications is associated with fewer problems. And we were able to break this down by females and males. Okay? So the first thing we did is just say, okay, in this data set, do people with ADHD, are they more likely to have one of these really serious events? Okay? And what you can see here from these blue dots is that roughly there's a 3-fold increase in the risk of having one of these major substance use problems. So practically, what does this mean? Okay? Across basically a 3-year period, 3% of males with ADHD had one of these events, compared to only 1.2% of controls. For females, it was about 2.5% to about 1% of controls. So most people with ADHD do not have this major substance use problem, but ADHD is associated with an increased risk, like 1% to 3%, or 0.8 to 2.6. We then said, okay, well, let's just look within ADHD patients. Did those people who get medication, did they have more of these problems or fewer of these problems than ADHD patients without medication? And you can see here that instead of being at an increased risk, those who had ADHD medications were associated with fewer of these substance use problems. Okay. Now, this could mean that ADHD meds are protective, but we also know that physicians are really reluctant to give people with substance use problems ADHD medications because you can misuse them. And I will talk about this at the end of the talk. So we're not sure if this is due to the ADHD medication or if this is due to something else. So our best estimate of whether or not it's ADHD medications or it's due to the ADHD is that with an individual comparison. So comparing individuals when they're on their medication versus when they do not have their medication. And when we did that comparison, we found that ADHD medications was associated with far fewer major substance use problems. Okay, so to be even more precise, male patients, okay, were 35% less likely to have a major substance use problem when they had their medication than when they didn't have their medication. Okay, suggesting that ADHD medications is quite protective for this really serious. Well, we then wanted to see, well, does this apply to different subgroups? And one really concerning subgroup is people who have prior substance use disorder. So if there are people on the call who are physicians in this field, you know, how do you treat people who have co-occurring substance use problems and ADHD? It is a really difficult question. It's a very difficult patient population. There's not a ton of guidance, particularly if you're working with adolescents with that comorbidity. And in our data set, we found that if you just look at this subgroup, ADHD medications is still associated with decreased risk of these major substance use problems. Okay. We then wanted to see, well, does it depend on the age of the patient? Again, there's a lot of debate about how we should treat individuals, particularly adults. And what we found is that really, regardless of people's age, ADHD medication is associated with fewer substance use problems. So it's not just among adolescents where it's protective, but it looks like across different ages, even among those who are 46 or older. We then wanted to see, okay, well, what happens 2 years down the line? Okay, everything I just showed you was on a monthly basis. What is the association between taking ADHD or having it in a particular month and that outcome? Here we are looking at, well, what is the prediction of having a substance problem 2 years down the line, given your ADHD medication status? And when you look at all patients, we found that ADHD meds was protective for future substance use problems. Okay. We also wanted to say, well, maybe it's not just taking the medication. What about the cumulative duration? Okay, so across 2 years, is more ADHD medication associated with more or fewer problems? And we found that more ADHD medication is actually associated with fewer problems. And then we wanted to see, well, is this just unique to ADHD medication? Or would this occur if you're treating anything? And so instead of using ADHD medication, we used SSRIs, which is a form of an antidepressant. So we wanted to see, well, is there something unique about ADHD medication, or is this going to happen if you treat any mental health problem? And we found that no, antidepressants are not associated with fewer substance problems. There seems to be something particularly unique to ADHD medications. All right, so that was a lot of blue dots and a lot of things related to ADHD medications and major substance problems. I'm now going to quickly just tell you a little bit about some of our studies in Sweden, because there are some major advantages of using Swedish data. So imagine Sweden is basically, obviously a country, has 9 million people, but think of it as a state, okay? And what they do in Sweden is they collect lots and lots of information, and they put them into databases. So we are able to link all of these national data sets. There's a multi-generational register which links parents to their kids. Because there's only one healthcare provider, that's the Swedish government, we know where everybody, when everybody took a medication or filled a medication, what type of medication it was, and how long the medication was for. We know every single inpatient hospitalization and anytime you went to a specialist. We know the diagnosis. We know their cause of death, crime. You can see all of these different things. We even know if you own a dog or have a pet because you have to register that. And so some of my colleagues who are really interested in, does being exposed to a pet when you're a kid, does that actually influence asthma and ADHD, not ADHD, asthma and allergies? It actually does. Actually, having a pet when you're a young kid actually reduces the risk of having later asthma. But anyways, we can do this across the entire country. Okay? And so I'm going to show you results from our analyses in Sweden using the exact same figure and the exact same method. So what is the association between ADHD medication and a number of different outcomes when looking at when individuals had their ADHD medications and comparing that risk to when they were not having their medication? And we were actually able to look at major depression. So again, showing up in an emergency department for depression. And ADHD is associated with less depression. We've also looked at psychosis, okay? And we were able to break it down among people who had previous psychosis or not. And we found that ADHD meds is actually not associated with more psychosis. Although some other people suggest that it might, our data suggests that it is not. Well, what about mania, okay? And what we were able to do is we were able to look at patients who had bipolar disorder and who had a mood stabilizer and people who did not have a mood stabilizer. And you can see in terms of these results that ADHD medications is associated with less mania if people are on their mood stabilizer. But this is actually really bad practice. Giving somebody a stimulant medication when they have a diagnosis of bipolar disorder and not on a mood stabilizer is associated with more problems. We also know about criminality. Every time people were convicted of a criminal offense, we were able to do this in the terms of the entire population and then among people when they were released from prison. And we found that ADHD medications is associated with less criminality, here associated with less recidivism. We published this in JAMA, one of the major medical journals, and there was a fascinating editorial which basically said, well, maybe a novel idea for the United States is maybe we should treat the mental health problems of our prisoners, especially when we release them. So that's just what we were able to do in Sweden. What we've been able to do is look at very similar outcomes in both data sets, okay? Because Sweden is a very different country, they have a very different healthcare system and all of that. And let's see if we can get similar or commensurate findings based on both US and Swedish data. So the first thing, and I think of most relevance to folks here, is, well, what about suicidal behavior? And so here, what we are looking at is what is the association with ADHD medication on having a severe suicide attempt? That's in the United States. In Sweden, having a severe suicide attempt or dying due to suicide because we have the cause of death register. And what we find is that actually ADHD medications is associated with less suicidal behavior. So people were less likely to attempt a suicide when they had a filled ADHD medication compared to the same individuals when they did not. In terms of substance use, I showed you the results from our major US study. We get comparable results in Sweden. So even in Sweden, ADHD medications is associated with fewer substance problems. Major motor vehicle accidents. People who have ADHD and who are of driving age are much, much more likely to have car accidents. Well, what about the effects of ADHD medication? And what we were able to find is that it's mostly protective. This is a really weird finding in Sweden. We didn't actually have a lot of women who had ADHD and were driving and had accidents, okay? But here we can see that ADHD medications is associated with fewer accidents. There's also accidental injuries. particularly really severe injuries that result in traumatic brain injuries. So traumatic brain injuries are obviously a really major outcome. They aren't that common, so you can't study them in randomized controlled trials. But we know that people who have ADHD are much more likely to have a traumatic brain injury. But we have found that ADHD medication greatly reduces the risk of having a traumatic brain injury. And then there's been concerns. We know that ADHD is sometimes co-occurring with epilepsy. And there's been this clinical lore that you should not treat people who have epilepsy with a stimulant because it may actually induce a seizure. So in the United States, what we were able to do is break it up among those with a history and not a history of seizures, as well as in Sweden. And we actually find that ADHD medication isn't associated with increased risk of seizures. It's actually associated with decreased risks of seizures. Now, we do not think that the ADHD medications are actually treating the cause of the seizures, but if this is helping them maintain their medication regimen, if it's actually helping them in terms of their other quality of life, if it is helping them keep routines and schedules, and a lot of the things that we know that ADHD medications can influence, that could then influence seizure activity. So at this point, I am done showing a lot of blue and black dots. So I'm going to just pause here and see if there are any clarifying questions from the chat before I summarize and talk about clinical implications. So Meg, is there anything that I should be aware of?
I'm not seeing anything. Nope, not yet. But if you do have questions, feel free to pop them in the chat and we'll get to them before this presentation's over.
Great. Okay, let me summarize and then talk about some implications. So from these within individual studies, we are finding that our results are sort of mitigating some of the really serious concerns that people have had about ADHD medications. Okay. Now, again, I have taken no money from pharmaceutical companies. I am not saying that there are not side effects, and I'll talk about those. But the major concerns related to substance use problems and seizures, we are not finding that in our studies. We are also finding that ADHD medication may be way more protective than we had originally understood, because we're able to look at some serious outcomes that randomized controlled trials have not been able to study, like major motor vehicle accidents and accidental injuries or criminality. What I want to point out is that these findings are consistent with some other within individual studies that have been done in other countries like Taiwan. They are also consistent with some other studies like randomized controlled trials. There's also some really interesting basic science research. So for example, there's a group of researchers who look at risk-taking behavior, and the way that they study it is they put people on a stationary bike and surround them with TVs. And what they show on TVs is a major highway, and you have to bike from one side to the other. And they test people who have ADHD when they're on their medication and when they're not on the medication. Okay? And in terms of getting across this really busy highway, the same individuals, when they're on their ADHD medications, are more cautious. They are less likely to bike out in between. Now, it's an analog study. It's not the same as actually trying to bike across a major highway. But what I'm pointing out is that the findings that we're getting in these really, really large data sets is consistent with studies that use other research designs. The other thing is that we're finding that ADHD medications may apply to some subgroups or at-risk groups that people thought maybe we shouldn't be giving them medications. So for example, I've heard a lot from families whose children have epilepsy and ADHD. And that's a really tricky combination clinically, but that their youth, their kids have really, really benefited from starting a stimulant medication. As you pointed out, in terms of recidivism, this is a really high-risk group, and we're finding that ADHD meds is associated with fewer instances of recidivism afterwards. Let me talk about some limitations, okay? So first is I can't say for certain that all of the blue dots and black dots to the left of that dotted line is actually caused by the ADHD medications. Okay, we're not randomizing people to get these and take them on a monthly basis. And there might be other factors that influence whether or not they're starting or stopping medications. And we're trying to rule that out, but we can't say for sure. And that's why I'm at least comforted by we're getting similar findings to designs that use different assumptions and have different limitations. There's also measurement concerns. So first is like, we are inferring that people are taking their medication. We are not in people's homes. We are not watching them take their medications. We don't know if they're taking their medications or not. So in terms of a research approach, this is more similar to an intent to treat analysis. The other thing is that we are indexing really severe events. There's reasons why we're doing that I can explain, but these findings might not generalize. Well, what about to minor injuries? Skinning your knee, falling out of a tree, that doesn't end up in terms of an emergency care or inpatient hospital stay. There's also questions about generalizability. At least in the United States, we have analyzed to date a data set among people who have insurance, that's provided by their employer. Well, what about people, for example, who have Medicaid? Medicaid is a federal program, as you probably most know, that really supports families that have disabilities, who are in poverty, or have eligibility, like being in the foster care system. Right now, 40% of children and adolescents are covered by Medicaid. Roughly 20% of young adults have Medicaid insurance. And what we're doing literally right now is analyzing a huge national data set of everyone enrolled in Medicaid, which is like 70 to 80 million people a year. Unfortunately, we don't have the results yet. I'd love to share them with you. But we have a question about, at least what I've shown so far, will this apply to youth who are in Medicaid and subgroups of youth who are in Medicaid? Will this apply, for example, among youth who are in the foster care system, arguably some of the most vulnerable youth in our society? We've also looked in general about ADHD medications as a large group or large classes of medications like stimulants versus non-stimulants. And there are questions about specific medications, and I'm happy to talk about what that may look like. For example, there are newer medications, newer within the last 10 years, that are more difficult to misuse and abuse in terms of their potential to cause highs. And there are questions about whether or not those are particularly effective related to substance use problems. We also don't know about the long-term effects. And this is surprising to lots of people. We don't know how long people should be on their ADHD medications. Randomized controlled trials aren't long enough. A lot of the longitudinal data sets that we've been able to analyze have not been able to tell us this. It's still an open question. How long should people be on? And what are the implications 5, 10 years down the line? The other thing is we haven't looked at all of the potential bad outcomes. And I'll talk about those in just a second. So first, well, what are the clinical implications? Well, first I want to point out that there may be a risk of not prescribing ADHD medications. We know that ADHD medications or ADHD in and of itself is associated with lots of impairment. And so there might actually be problems with not prescribing. And this is something that I know that pharmaceutical companies love for me to say. Again, I'm not saying that everyone should be on ADHD medications and all of that, but I want to point out that we have to factor in the risk of having ADHD in and of itself. The other thing, and this is really being debated right now, there are no treatment guidelines, for example, for how to treat adults with ADHD. And AFSPIL, a major national organization, is actually still working on these treatment guidelines. And we have found protective effects, even amongst adults, particularly for substance problems, accidents, suicide, and criminality. So when my colleagues and I were on a Zoom call, colleagues in Sweden, and I was here in Indiana, one morning, we were like, well, should we put it in the water? And I looked around, and we all were drinking coffee or tea at that point. So I want to point out, like, in many ways, it's already in the water. Stimulants like caffeine, a lot of people are using, but no, we shouldn't put it in the water. There are other outcomes. There are other things that ADHD medications impact, like it can cause sleep difficulties. If you're giving someone a stimulant, it can have big implications for sleep difficulties. Most people get over that side effect after about 2 to 3 weeks, but not everybody. There's also implications for stature. So if you're on these medications for a long period of time, youth may actually be about 1 centimeter shorter on average. And there are other adverse events. Some of them are really, really rare, like cardiac issues. So there is no magic bullet in psychiatry, and ADHD medications is no different. We are not able to specifically just target the ADHD symptoms and nothing else. I want to point out that there are these other side effects that do have to be factored in when making treatment decisions. And part of this as well is that there's also a lot of societal problems related to the diversion and misuse of prescribed stimulants. So this was a paper that was published in 2018. There's a shorter article that just came out a couple of months ago where they present how many people are misusing prescription stimulant use or prescription stimulants. So this is using someone else's prescription or using more than you were prescribed to use yourself. And physicians can do a lot to counteract this, okay? Part of it is that we have to be more aware of that this is happening, and we have to educate our patients about this, talk about how illegal it is, maybe not give people 3 months or 90-day supply, but give them smaller increments where they have to keep picking them up. There are things that you can do to mitigate this, but I want to point out that we're actually showing that ADHD medications may be incredibly protective for people with ADHD. There may be also some societal harms with more and more prescribed stimulants out and about. So for example, I'm sitting in the psychology building. Right across the street is the library. And during finals, in a week and a half, you can go and for $25 easily get a stimulant medication to help you cram because you haven't been studying for my final until the very last week of the semester. These are prevalent and you can get access to them. They can be incredibly dangerous. Okay, so some meta messages before I open it up for questions. The first is that I hope that I have been able to convince you that yes, randomized controlled trials are great, but they're limited, and that we can supplement them, and that large-scale observational studies can inform our understanding of ADHD and how to treat it, okay? And that randomized controlled trials are not the only way of studying interventions, particularly for mental health problems and particularly for ADHD. And without the ability to randomize, what researchers have to do is we have to be very, very creative. We have to be honest and open about the limitations of using these data sets where we're not randomizing people to get a medication or not. And we have to be very clear about what we can and can't say about that data and use sophisticated designs and use sophisticated approaches in terms of our analysis of these data sets so that when we present to community partners, to physicians groups, when I'm helping to train medical residents, that we are able to give them the best evidence base to guide their decision-making when they're going on in practice. And arguably, the hope is that the insights from these studies, we're targeting clinicians, and hopefully they will be sharing this information. And in fact, some of the new treatment guidelines suggest that educating patients and their families about some of these large-scale observational studies, like injuries, can actually be really, really important so that patients and their families understand what are the risks associated with having ADHD in and of itself, and what are the risks and benefits of these medications. And that the results of some of these studies can actually be very helpful in working with patients and collaborating with them to come up with the best treatment plan, and to continually update that treatment plan depending on how patients and their families are doing. So at this point, I want to say thank you. I'm sorry that there were so many blue dots. Hopefully they were not too overwhelming. Hopefully it wasn't too much research methods, and that I was hopefully able to help provide some insight on ADHD medications, and rare outcomes like substance problems and suicidal behavior. So I will stop